Good morning. Thank you for getting out of bed for the first talk for the day. So instead of really focusing on my experience, I just want to really offer just a few points that I've learned over the last 6 years and focus on that. And these are the topics that I'll be covering is really full-length complete treatment, an occlusion technique for ultrasound-guided sclerotherapy, keeping your foam cold, staging procedures, and not being afraid to treat venous disease before arterial. So I've always used the 1470 nanometer laser radial fibre, single use, always local anaesthetic and tumescence, no sedation, and no fasting. So I use the radial fibre because it's safer, it's not painful, and it has 1/9 of the fluence of a bare tip fibre, so you get less perforation, you can use a much lower wattage. So I've got 6 years' experience. My first results were presented, first 250 odd patients at Vascular 2012. Done over 1,300 laser procedures now. Success rate remains close to 100%. We're currently doing a full retrospective analysis and putting together a prospective database. So all trunk veins are lasered. Complications remain minor, so we've only ever had one minor wound infection. Pain score, visual analog scale, during the procedure averages 1.59 out of 10. And post-procedure, including day of, less than 1 out of 10. So less than 50% of patients take any analgesia whatsoever. Again, that's the beauty of the radial fibre. Bruising's rare. We've had no skin burns. Had one major complication, which is asymptomatic. And interestingly, it's in the great saphenous vein stump, so I think it's probably related to an injury from the tumescent needle. And we've had a single deep venous thrombosis, which was a minor calf thrombosis, of course, in another doctor, and was an area that was previously thrombosed due to calf trauma, due to a sporting injury. So let's just go through a few tips. So this gentleman is face down. You can see the entry point at the ankle. The important point here is to inject tumescence before you put the sheath in, because it's a 6 French sheath, and if you invaginate the vein, you don't want to tear the nerve. So we did a safety and efficacy study of 162 consecutive patients when we started treating from ankle, and we wanted to make sure that we weren't going to end up with any neuropraxia that was going to be of any significance. So you can see that, interestingly, the orange section is the ankle entry points, and the neuropraxia in the first 1 week to 3 months is most commonly found when you do enter at the ankle. However, they all resolve, and we've got one patient, another doctor, an ophthalmologist, who's got numbness still, 50-cent piece at the ankle, and she's not bothered by it. That's at 12 months. So what we've found following these patients up over 5 or 6 years is that I used to just treat the incompetent segment. I'd always say to patients, if it's not broken, don't fix it. But inevitably, they develop more distal incompetence in the same trunk vein. And I tell you, they're very unhappy when you tell them you have to laser the same vein again, just a different segment. So this technique I designed a number of years ago. I've named it after a patient because he made some of our first acute occlusion devices. We now use digital occlusion. We map out on the patient where all the drainage points are for the tributaries, and if it's communicating with any major trunk veins that we don't want the foam to go into. And the nursing staff provide digital occlusion to stop the foam travelling. Interestingly, in the literature, people describe common side effects with foam sclerotherapy, such as chest tightness, coughing, visual disturbance, which we're told is biochemical, it's not embolic. I disagree, I think it is embolic because we don't see that in any of our patients. We use liquid sclerotherapy in any patient that has migraine with aura because their risk of a hole in the heart is double that of the normal population, so normal population is 1 in 5. So instead of sending them for a bubble study echo, which also has a risk of stroke, we do liquid. Something I learnt from Kirosh Parsi at the Boston UIP meeting a number of years ago is to keep your foam cold. You get much better bubble stability, so keep your ethoxysclerol in the fridge, keep it on a cold pack, and we use an alcohol-soaked gauze during the procedure, and the bubbles stay nice and stable. We've reduced the need for phlebectomy significantly. Only 5% of our patients who were initially planned for phlebectomy now go on to have phlebectomy, and that's because we stage the procedures. So the picture on the left, this gentleman's had endovenous laser and then sclerotherapy, and you can see the veins retracted beneath the skin. And on the right, this gentleman's had laser only. Another thing I learned in Boston a couple of years ago, Hugo Parch, who's the doyen of compression, has done a number of studies now looking at the fact that treating venous disease actually improves capillary perfusion in those with arterial disease. So I've got a low threshold now to treat venous disease before arterial. This lady had a mixed arteriovenous ulcer. I placed her into compression, it got worse, then immediately treated her veins. The ulcer healed very quickly. It remains healed now 3 years down the track, never recurred, but she's had 7 venous interventions in that time, including laser and injection sclerotherapy. So prevention requires ongoing surveillance. So in conclusion, use a high wavelength laser with a radial fibre. Stick to 40 joules per centimetre below the knee if you don't want a nerve injury. Do treat from the ankle. Use an occlusion technique for sclerotherapy. Keep your foam cold. And stage treatment avoids phlebectomy in most of your patients. And don't be afraid to treat venous disease first. I just want to thank one of my nursing staff, Andrew, who's been with me for the 6 years, who helped me put together a lot of this data for the talks today. Thank you.